So chapter 49 on diabetes, we're going to actually spend quite a bit of time on diabetes. This will be a big portion of your exam, and we're going to focus on type 1 and type 2, a lot of the treatment, so patient education for nutrition, activity, drug therapy, and then we'll also cover acute and chronic complications. I'm sure most of you have cared for a client with diabetes at some point this far in the nursing program. Diabetes is a devastating chronic multi-system disease. It affects 29.1 million in the United States, over 9% of the population. And even a scarier statistic is 8.1 million individuals are not even aware that they have diabetes. So they're already at risk for developing these complications with no patient education or treatment on board. So that's a really scary statistic. So all of us are doing clinical on med-surg floors, either at Glens Falls Hospital or Saratoga Hospital, or we have been up until this point. So I'm curious how many of you have cared for a patient this semester or past semesters with an amputation secondary to peripheral vascular disease related to diabetes. So a toe amputation, a below-the-knee amputation, possibly a client in end-stage renal disease from diabetic nephropathy, all related to chronic complications from diabetes. I know many of you at Saratoga were doing rotations through the dialysis center, and some of you at Glens Falls may have cared for a patient on dialysis. So these are the serious chronic complications that we're really focusing on preventing in our diabetic population. Also, perhaps you've cared for a client that was legally blind due to diabetic retinopathy, or possibly had all three of these. Diabetics are 2 to 4 times more likely to die from a cardiac event. So 50% of diabetics, adult diabetics, will have high cholesterol and hypertension and cardiovascular disease. So that's the number one major concern, a cardiac event in our diabetic population. So a lot of our education, a lot of the medications that we're going to be administering and teaching our patients perhaps might be for hyperlipidemia, antihypertensives, in addition to oral agents or insulin therapy to control the hyperglycemia. So diabetes can be caused by genetic factors, an autoimmune reaction. So if a client has the presence of a certain antigen, they can be exposed to a common virus, and that can trigger an autoimmune destruction of the beta cells in the pancreas, which, as you know, produce the insulin. There can also be environmental factors. It could be a combination of any three of these, and diabetes is really either not enough insulin, so complete absence, or insufficient insulin, or poor utilization of the insulin. So that's what we're really going to talk about when we compare type 1 and type 2 and what's going on. So there's 4 types of diabetes. Type 1, so used to be referred to as juvenile diabetes. Type 2, which is responsible for the majority of cases. Gestational, which is covered in Nursing 103. We're really not going to spend a lot of time on gestational diabetes. And then other types of diabetes. Can anyone think of any other types of diabetes other than type 1, type 2, or gestational? Maybe some of you are thinking of a client with chronic pancreatitis, which really had no history. The client had no history of diabetes, but now due to this condition involving their pancreas that is chronic, they no longer have function of their beta cells and they are diabetic and they are requiring insulin therapy and glucose management. Another condition we just covered, one of our endocrine disorders, but it could be a client with Cushing's disease. That excess production of the counter-regulatory hormone cortisol that's causing this hyperglycemia. It could be clients on chronic drug therapy that causes hyperglycemia. So perhaps, a client that's on corticosteroid therapy that is now diabetic. This table is comparing type 1 and type 2, and I'll let you take a look at this. I do just want to point out a couple things. Type 1 can occur at any age. It does not have to occur in our younger population. It's not as common to have a new onset of type 1 as an adult, but it is certainly occurs. Type 1 also, the symptoms are very sudden. So when a client reaches the point where they have destruction of their beta cells and they no longer have insulin production, they are having this, sudden onset of symptoms, the polyuria, the polydipsia. They're severely dehydrated and they often present in an emergency state. So if you work in an urgent care or an ECC or you plan to work in those settings, that would not be uncommon to have a client present with these symptoms that have suddenly come on over the past couple days, and they're in a diabetic ketoacidosis state, could be critical state, and they're an undiagnosed type 1. Type 2, type 2 has a very slow onset, so a lot of vague symptoms that a client may not know for a period of years if they don't have regular medical care. So that's really concerning. Somebody that could be a type 2 diabetic for 5 or more years and be at risk for starting to develop these chronic complications and really not aware of their diagnosis. So the importance of screening high-risk populations and regular medical care is really important. There's different causes of type 1 and type 2, but I'll let you read through this table and we're going to go into more detail on the other slides. So the major difference in type 1, there's absence of insulin. In type 2, there's a decreased amount of insulin and possibly poor utilization of the insulin. Again, the symptoms of type 1 would be very obvious: the polyuria, polydipsia, weight loss, fatigue. Insulin is really necessary to allow glucose to enter the cells for energy, and when there's absence of insulin, the body starts looking for other sources of energy, and that's what you're looking at with ketosis and the weight loss. Type 2, a lot of times, like I mentioned, clients do not have symptoms for a period of time. As the type 2 worsens, that's when you're really possibly going to see the polyuria, polydipsia, polyphagia with type 2, but a lot of the earlier, it would be no symptoms or recurrent infections, a minor injury that's just delayed healing, just really just vague symptoms. Type 1 is definitely going to require insulin. Type 2, a client may be able to manage their diabetes with diet, exercise, then possibly oral agents. It is a progressive disease, so eventually they will most likely require drug therapy, even insulin therapy, as their beta cells continue to not continue to decrease in function. So we talked about the B cells. Insulin is normally continuously secreted in small amounts 24 hours a day when you have a normal function of your beta cells. Normally, your body, with the counterregulatory hormones and the insulin from the beta cells, can manage your blood glucose between 74 and 106. So that is not the fasting blood glucose that's on your Nursing 104 list of lab values to know on Blackboard, but this is throughout the day with your insulin production and your counterregulatory hormones, normal function in a non-diabetic, that's normal glucose and insulin metabolism. So again, insulin is normally secreted in small amounts continuously, 24 hours a day, so that background insulin. And then around mealtime, you're going to see that spike 1 to 2 hours after a meal. Insulin rises and then returns to the preprandial level. So you can see those spikes right around mealtime. So when you're in clinical and you're administering perhaps a rapid-acting insulin or a short-acting insulin before mealtime based on a client's blood sugar, perhaps a sliding scale, or maybe your client's on carb coverage, that's to cover these spikes in our diabetic client. So again, insulin binds to the receptors on the cell and allows glucose to enter the cell for energy. So if you want to think of insulin as the key to allow glucose to enter the cell for energy, that might be helpful, because as we talk about some of these acute complications, that visual can be helpful to think through what's going on. So hopefully by now, if I were to ask you to name 3 or so counter-regulatory hormones, you would be able to quickly do that. That's going to be something that's important to know. So we've already talked about growth hormone from the anterior pituitary, how it opposes the effects of insulin. Cortisol from our adrenal cortex, again, opposes the effects of insulin. One of our catecholamines, epinephrine from the adrenal medulla, same counterregulatory hormone, and then also glucagon from the pancreas. So these oppose the effects of insulin. They stimulate glucose production by the liver. They decrease movement of glucose into the cell, and they help keep that balance between the normal balance of blood glucose. So between insulin and counterregulatory hormones, normally your body's able to maintain a normal blood glucose. Type 1 accounts for 5 to 10% of people with diabetes. That has increased over the past 5 years, so it was closer to 5%. And now it's 5 to 10%. So the reason for that is really unknown. It's really an autoimmune genetic cause for type 1. Again, it usually is in your younger client, but it can occur at any age. So with type 1, it's really these antibodies that are causing destruction of the beta cells, so it eventually the client requires insulin. Again, once the beta cells completely decrease in function, that's when you're going to have this sudden onset of symptoms, and usually it's acute. So again, the client does require insulin. Sometimes they have what they call as a honeymoon phase initially after they start treatment, where they require very little insulin and they start to feel a lot better months after starting the treatment, because there might be some slight function of those beta cells, but then within a year that kind of goes away. So type 2, the most common form of diabetes, risk factors, family history, obesity, advancing age, certain ethnicities that are at a higher risk, Asian American, Native American, African Americans are at a higher risk. And also with the increase in childhood obesity, we're seeing a lot more children that are being diagnosed with type 2 diabetes. And I think many of you know there's a lot of focus and intervention in the schools for healthy lifestyle, healthy eating. So type 2, the pancreas still produces some insulin. It's usually not enough insulin, and or the body is unable to use the insulin effectively. So that's the big difference between type 1, where there really is absence of insulin, and then type 2, where there's not enough insulin or it's not being utilized properly. So with type 2, like we just talked about, there could be several things going on. So insulin resistance, so that's where, like I mentioned, the body is not able to utilize insulin effectively, so tissues do not respond to the action of insulin. And when insulin can't be used, glucose is unable to enter the cell for energy, and it accumulates and causes the hyperglycemia. There could be, most often there is, decreased insulin production by the beta cells in the pancreas. It could be fatigue of the cells. It could be for reasons that are unknown, but there's not enough insulin being produced. Inappropriate hepatic glucose production. So the liver is releasing glucose at inappropriate times. It's not really responding to the body's needs, and it's contributing to this hyperglycemia. There also can be altered production of hormones and cytokines that are causing chronic inflammation, which contributes to this hyperglycemia. And there's continued research on more and more factors that are contributing to this type 2. This is a visual out of your textbook, just kind of comparing type 1 and type 2, if you want to take a peek at that. So clients that have metabolic syndrome are at an increased risk for developing type 2. So these patients would really be screened regularly, and lifestyle modification would be super important to help prevent the onset of type 2 diabetes. But it would be any presence of 3 of the 5 of these. So increased glucose levels, obesity, hypertension, high level triglycerides, decreased levels of HDL. So type 2, usually gradual. It's often diagnosed with routine blood work. So perhaps a client having blood work done for pre-op for a minor outpatient surgery, or a routine physical, because again, a lot of times patients are not experiencing any symptoms. 50 to 80% of the B cells are usually no longer working when a client is diagnosed with type 2 diabetes, and it could go on for years without being detected, again, if they don't receive regular medical care. So the average amount of years is 6.5 years, and that's a really long time. So there's a big focus on decreasing the amount of years and early identification. So clients that are pre-diabetic are at increased risk for developing type 2. So again, an opportunity for lifestyle modification, weight loss, nutrition, activity. So the presence of any one of these, a client could be diagnosed with prediabetes. So an oral glucose tolerance test of 140 to 199. And again, that's when a client would ingest an oral solution and then have blood glucose levels checked at certain increments. The impaired fasting glucose, 100 to 125. Remember, the normal fasting blood glucose would be less than 100. You do always want to make sure that the patient truly was fasting, that they're not on any medications that could cause an increased blood glucose. So like I mentioned, gestational diabetes we're not really covering in 104. I do just want to point out a couple important pieces. It is an issue in 2 to 10% of pregnancies in the U.S. It does increase the risk for complications. Clients that are high risk, so if they've had a previous pregnancy where they had gestational diabetes, or if they have risk factors, obesity, etc., they would be advanced maternal age, they would be screened earlier. All clients are screened for gestational diabetes, and just, the higher risk patient would be screened earlier. And a client that has gestational diabetes, they have a 63% chance of becoming a type 2 diabetic within 16 years. So this is an opportunity to really do intensive education on lifestyle modification to prevent this onset of this chronic multi-system disease. So this is really, if you're going into maternity nursing, a great opportunity for patient education and making a huge impact. So we briefly talked about other types of diabetes, Cushing's, chronic pancreatitis, even hemochromatosis that you covered with Justin. I also mentioned certain medications that could cause diabetes. So we talked about chronic corticosteroid use, also some of your antipsychotics. So it really could impact a variety of different patient populations. So this is an important slide to know, the clinical manifestations for type 1. Remember, these usually have a sudden onset, and it's going to be extreme thirst, so that polydyspia, polyuria, and polyphagia. Those are very classic with type 1. They come on suddenly and they're very pronounced. Clients experience weight loss with type 1. That's an important piece. Because the client has absence of insulin, they're unable to get glucose into the cell because they don't have that key, that insulin, so the body kind of turns to fat and protein for energy, which is causing the weight loss. Due to the lack of glucose for energy, the patient's also experiencing weakness, fatigue. If this goes undiagnosed for days, ketoacidosis. So type 2, remember we said slow onset, a lot of times no symptoms for an extended period of time. Then the client may experience fatigue, a recurrent yeast infection, for example, a minor cut that just doesn't seem to be healing. They might be having some blurred vision. As things worsen, they could have the symptoms of type 1, the polyuria, polyphagia, polydipsia. It's just not as early and as sudden and as pronounced as type 1. So diagnostics. You only need one of these to be diagnosed with diabetes. So a hemoglobin A1C of 6.5 or higher, fasting glucose of greater than 126, an oral glucose tolerance test of greater than 200, or classic symptoms of hyperglycemia with a random level of greater than 200. Usually more than one of these is performed to diagnose diabetes, and you always want to make sure, again, that the client, if it was a fasting blood glucose, that they were truly fasting and really doing a thorough med list to make sure there's no medications that can impact glucose, and it really should be repeated again to confirm the diagnosis of diabetes. So hemoglobin A1C, this is one of your important diagnostic studies that you definitely are going to want to start and know this for sure. Hopefully you've been looking at this in clinical for your clients that are diabetic. This gives you great information. We just talked about it being a diagnostic criteria, but it also gives you good information about a client's overall blood glucose control and treatment. And a lot of times treatment will be adjusted in a known diabetic based on their hemoglobin A1C. So I want to specifically just mention that it's the amount of glucose attached to the hemoglobin over the past 2 to 3 months. So the normal lifespan of a red blood cell is 2 to 3 months. So that's why it gives you that time frame, that information. You really want it to be less than 6.5%. I know your slide says 6.5 to 7%. The lower the number, the better glucose control you have, and that's really important to prevent those chronic complications that we talked about. So I do have a link here that I'll let you look at. But sometimes if you're sitting down and you're doing patient education with a client and you say, you know, we really want your A1C to be at 6.5, that might not make a lot of sense to them. It might not give them a good picture of what you're talking about. So if you can show them this table, if you click on this link, and for example, if their hemoglobin A1C is 8, that means for the past 2 to 3 months, their average blood glucose is in the 180s. That is probably not their target. So that might just give them more information. I did take care of a patient who had a hemoglobin A1C of 18. That's crazy high. He also was legally blind. He was on dialysis. He had bilateral above-the-knee amputations. He had severe neuropathy. He had suffered an MI. So he really had very poorly controlled diabetes for a long period of time, and he had many chronic complications. So hopefully you don't see any patients with a hemoglobin A1C that high, but it's not uncommon to have somebody walk into the ER that has a hemoglobin A1C of 10 or 11 or 12 and is walking around for the past 2 to 3 months with a blood sugar in the high 200s, which is not great. So just take a peek at that link just for your own information, nothing that you have to memorize. I do want you to know that you really want a hemoglobin A1C 6.5 or less, 6.5 to 7. But again, the lower the number, the better the control. also just want to mention one more thing on the previous slide. If your client has iron deficiency anemia or sickle cell, perhaps their A1C will be altered. So I just wanted to mention that. So the overall goals of diabetes is to really have good blood glucose control. That's the number one goal, and that's going to prevent these complications that we're going to talk about, but also patients are going to feel better and not experience acute complications either.